is a pacemaker wire, but it's Swan-Ganz, okay? So this is designed to float a lot longer than your standard central line, okay? So, and the reason for that is because this is designed to access through a port, go all the way down through, and actually get into your pulmonary artery. So it's got to be super long, all right? And when it's in that pulmonary artery, it's making all kinds of moves. So you'll see it on X-ray, okay? And I'm going to go over how this thing actually works real quick. This right here is the pacer, okay? So this is actually a pacemaker. These right here are the connection ends that go into a standard pulse generator, all right? So now, if you have the wrong fitting or a different fitting, Arrow makes adapters. So this will typically fit most, and it'll tell you the distal and proximal port. It'll be listed right on there, okay? All that you need to do to make this an external adapter versus internal is just put these little pieces on here, and all you're doing is you're moving the contact outward, okay? And then those would plug in again to your distal and proximal, all right? With anything that goes as far as the pulmonary artery, what you need is a balloon on the end, okay? Because what you have to do is you have to be able to seal it so that you can get a pressure reading on the opposite side. So in the way that that works is you're going to have a syringe that comes in every one of these kits, all right? And there's a small syringe. These syringes do not turn like a standard syringe, so you know that it's the one that's supposed to be on there, okay? So just be aware of that. And it won't pull all the way out, which is the other piece of it. You see there, you can't pull the plunger out. So they're designed that way for a reason. What I will tell you is when you're transporting somebody who has anything that's Swan-Ganz, anything that's pulmonary catheter, if this syringe is in there, okay, take the syringe and pull back and let it go. There should be, it should pull right back down to normal, right? It should pull right back down to normal here, all right? If you pull back and it stays open, it means that the balloon was inflated. That's a problem, all right? So it should always go right back to normal. You can take it off and put it back on and pull, and it'll pull it right back down to normal. It's a vacuum, it's supposed to do that.
And if it doesn't?
If it doesn't, there's a problem. And you can ask them to troubleshoot the problem before you leave. This syringe should always be all the way down, and it should be taped when you start your transport. Keep it taped. There's no reason for you to ever wedge a catheter. If you wedge a catheter, right, and it's in the pulmonary artery, and that balloon's up and you can't get flow, guess what happens? The pulmonary artery says, so long. And once that's gone and that's dead, the patient's dead too. All right? So this right here is the balloon, and you can see I can't inflate it. Okay, if this is connected and it's all the way down, I can't inflate it. However, if this has air in it and I put it on here, and if you watch the balloon here, it's a teeny tiny balloon. Now it's inflated. You see how it's designed to always drop back, okay, one way or the other. Once you close the circuit, it's always designed to maintain pressure in the syringe versus here. This is higher pressure, this is lower pressure. Pressure always goes from an area of higher pressure to lower pressure, all right? So this right here is what causes all the problem inside of the pulmonary artery, okay? Now, why would you ever inflate a balloon? Well, when you inflate the balloon, it gives it something to pull, right? So if I'm just floating this down through and I'm having problems getting it, so this is going to go through the subclavian vein, and it's going to go down into the right atrium. It's going to go down through the valve. It's going to go into the right ventricle, and then it can move all the way up into the pulmonary artery, right? It's just a pacer. I don't need to go into the pulmonary artery, okay? Sometimes they will put it in the right ventricle, sometimes they'll put it in the right atrium. Where's your SA node? In the right atrium. So really, if you can capture up there, that's what you want to capture. If you can't get capture in the atrium, then you drop it to the ventricle. The ventricular rate's more important than atrial rate, right? Think third-degree heart block. You're going to have a atrial rate of 100, but your ventricular rate's 12 to 20. Your problem is you're not perfusing the brain. You're in cardiogenic shock. Right? So with this here, the reason why I would inflate the balloon is I'm not able to move it, so what I want to do is inflate the balloon so it puts a little drag on it and pulls it, okay? Because blood is always going to be moving from the atrium down into the ventricle. It's only for insertion, that's it, okay, and for floating it. Once it's where it needs to be, they deflate it, okay? So, and some places, and I don't know why they do this, but some places have gotten to the point where they're like, we'll leave the syringe on and the plunger all the way out indicates the balloon's down. this off, squeeze it out, put it on, and then tape it. Why do I like it that way? Because you can have this, and there's no pressure, and you can't inflate the balloon by accident.
Getting it down.
Exactly. Whereas if this is on there the way that some of these places want it, right, and you hit that by accident, now you're in trouble. Okay? So I always want this on there with the syringe down. And again, we'll do that again, blow up the balloon and disconnect it. You can see it's an open system, right?
That's the one that a lot of times they tape to the patient, right to the patient's body, right?
Mm-hmm.
You'll see them like tape that thing with an X over it.
Mm-hmm. Yep, with an X over it. Yeah. All right, so, and troubleshooting something like this, right? So they're pacing, you're looking at the pacing spike. You see the pacer spike, you see the QRS complex, you know they're pacing the ventricle, and then all of a sudden you don't have any ventricular capture anymore. This moved. Like you'll be able to see the pacer spike moved further away from whatever the capture site was. So that's kind of a neat little piece too. Now, the way that this would get inserted, okay, and the way that central lines get inserted is basically what they're going to do is they're going to take a large needle, right? They're going to prep the site. And I'm going to go over the actual landmarks, but they're going to go down into the site. So anytime that you put a big long needle in here, what can you end up doing? This is, pneumo. Not only that, what's up in here? All the great vessels, right? That's above the first and second rib. So just be aware of that, and you want an X-ray. Anytime that you have an invasive line that's above the diaphragm, you need to look at the X-ray. Okay? An invasive line below, not so bad. They get infected, but there's not a whole lot. Not a whole lot you can damage down there. But you know what I mean.
You're not going to kill the patient.
You're not going to kill, yeah. Well, you might kill their 1%, but settle down. It's not that important. All right. Well, I'm talking about you, not me. So you go in, right? They're going to go in. They're going to puncture the subclavian. All right. They're going to inject. They're going to put a bunch of lidocaine in that space before they puncture the subclavian. Then what they're going to do is they're going to take a.
Because that's relatively painful, right?
What's that?
If they're not using,
Yeah, it's not.
That's why they'll numb it up. They wait.
It's not super fun.
They do like central lines, yeah.
What's that?
In the helicopter.
Oh yeah. These needles right here, okay, are super long, and they go in that space as well. So there's a couple of different ways that they can introduce the central line. So usually it's introduced with a wire, okay? PA catheters, sometimes they introduce with the wire as well. So it's just a simple introducer wire. It can go through a metal needle, okay? Or it can go through a sheath. So if it goes through the metal needle, you can see here it's curved, right? And all they do is they hook it on the catheter and then slide it. Once they slide it in there, it straightens out, okay? I like when they use the sheath and they leave the sheath behind, because then you can move things in and out of there pretty readily, all right? So on the sheath, it just slides in like so, and this little piece right here slides in, and then they just use their thumb here and they just roll that wire down. So why are they doing that? What they're doing is they're puncturing the subclavian, and then this sheath sits inside of the lumen of the subclavian like so. So here's the subclavian. So if I'm running this wire through,
Putting a gun bougie.
yep, exactly. I know that the wire's in the right place, okay? Then what I'm going to do is I'm going to slide the wire all the way off, okay, like so. And this is garbage, okay? Then what they're going to do is they're going to pull the sheath, and the wire's sticking out of the patient's throat, okay? And then at this point here, I take the catheter.
Well, it's like placing the bougie or something.
Yep. It's exactly that.
Just getting access, and then you're using that as your.
And then this is going to go over here, okay?
You're gonna feed that in. That wire's still in, and then pull the wire out.
Just like so.
And as that catheter feeds down, does that take that hook out of there?
Yeah, you'll see.
So
It's going to come up, and you'll see it come
kind
through
of
the
in
cap.
place while you're messing around.
And your blood cap is the first one, okay? So brown is always blood. There's your wire.
Will you ever get like a flash in that?
Oh yeah.
Once you, okay.
Oh yeah. If you need to access blood, that's your distal port. That's a 16 gauge. You can get blood through it. You can draw blood through it.
Okay.
So right now, this would be sitting in the space. I always leave these on until I can start to see the wire come up through, because otherwise it's just going to keep bleeding everywhere. Okay. You can clamp any one of these lines at any time. Okay. So what's going to happen is they're going to thread this off, and then they're going to pull the wire. And now this is in the subclavian and it stays in.
A lot of the hospitals change these though. They don't keep these ports.
Right, they put the
Okay.
end
One
cap
way.
different.
Once it's used,
Yeah.
it's
So why would you
garbage.
do this?
If we couldn't get access in the past, we used to do central line. Now we drill. I mean, everybody drills, but we used to do ephemeral central lines just for access.
These are a little more permanent, more long-term, better for long-term, right?
Yeah, actually, you know, with CLAPSI, the central line acquired infection, blood infections, they tend not to put these in the subclavian as much anymore. They do IJs more so. They almost never use the femoral line. These can stay in for indefinite periods of time, but typically they're
You have to
in
put an
for less than a
anticoagulant
week.
in those though, right, when they go in?
Not necessarily. Not
They
necessarily.
don't.
They don't
fill
always
those
do
with,
it. They don't always do it. They can put a little bit of heparin in there. I mean,
We don't
Anytime
now
I've-
anymore.
you don't. Yeah, you don't.
You
You don't
don't.
really have to.
Anytime I've ever had to
Yeah.
access one, you know, like a dialysis
Heparin-induced
patient.
thrombocytopenia.
Yeah. Anytime I've ever had to access one, like in an emergency,
It's
when we couldn't
clotted.
get access. Well, it's either clotted or it actually has, you know, you have to, I always draw back first to see if you get a bunch of fluid before you get,
Yeah,
blood
yeah.
out of it, and you know
Yeah.
it heparinized.
And that's,
Yeah.
I'm going to show that too, so that you have an understanding of that. So there's two little suture points on here. Okay, you see the little holes there?
Stitch it to the skin.
And it's going to be stitched to the skin. There should be a dressing over it as well. Okay. Now I'll leave all of this stuff with you. You guys can monkey around with it all you want, so you see.
The premise of that little hook is just to keep it, if you're not moving it, it keeps it kind of in place, right?
Well,
It produces a little tension inside
So,
the-
so while they're doing the insertion, you don't want this thing moving out for any reason.
Right.
And what ends up happening is that this is in the vessel wall and it just flips up and it kind of anchors itself on the
It
other
just
side.
creates a
of the
little bit of
vessel.
tension enough
Yeah.
to keep it.
That's it. All right. So, okay.
We see our lung doctors a lot of these.
All right. So this here, you're familiar with the balloon. The balloon should always be deflated. That's key number one.
Now, if that ever dislodged or floated deeper into the, anywhere in the heart, and they're not pacing as well, would you just disconnect that and go back to patch pacing?
It's going to come down to what you have written as an order.
Okay.
So, how are you going to know where this is? Because there's different lines on here for documentation. So it goes 1, 2, 3, 4.
Okay.
1, 2, 3, 4.
You'd have to look and see after.
I mean, those are pretty big gaps between
When
those
you
two.
troubleshoot.
You wouldn't notice if it slid.
Oh,
Unless,
A
You
quarter
can
of an
mark.
inch.
You can mark on this.
We're allowed to.
You can write on this with a Sharpie.
Okay.
Okay. So when this is in place, you can write on that with a Sharpie where it enters and exits the skin.
Okay.
And if you notice that it's in the wrong place, or if it's pulled out or whatever, some
Readvance.
places will write the orders that you can't advance it. Okay, some
Okay.
places will say no. So it's going to come down to your medical control whether or not they want you to advance it. If they say no, the only option you have is
External pacing.
transcutaneous pacing, right? If you're doing transcutaneous, you don't want to do this. You want to do front to back. You're going to get better capture.
Okay.
Okay.
So if you have an issue with that, would we leave that in place, or would you actually withdraw that?
Don't pull it all the way
Yeah.
out. Never pull it all the way out. You always
just-
want to leave it inside the sheath at a minimum. This should always stay in the patient.
It's not going to create an issue if you're pacing externally.
The only time that you're going to pull it is when you notice that it's gone into wedge, the balloon cannot be deflated, or there's a major problem. You're going to pull back, but you're not going to pull it all the way out. Okay.
To get it up out of the heart.
Yeah. So let's say I'm transporting it and it's at 2, right? And all of a sudden I noticed my waveform was like this, right? Which would be, so a smaller waveform is what you're going to see in the atria. You float it down through the ventricle, and because there's higher variations in the pressures, you're going to see a bigger waveform, right? And then it floats up into that tiny little pulmonary artery. So it goes like this, then it goes like this, and
So
then
it's
it
going to
goes,
get longer.
right, and then it kind
Flatten
of
out,
flattens
right?
out.
Yeah.
You see it flattened out, and you see that, hey, I started at 2, and
You know it's
Now you're
actually
at, like,
advancing.
yeah, now you're past the 3. Well, let's get back to 2. That's our starting point. That's troubleshooting. Okay.
Okay.
All right. So back to this here. So now you've got your different chambers, right? Now, typically, the way that these are designed is that brown is always going to be your blood port. Okay. And then your medial port is white. That's typically drugs. And then this blue one is going to be like your last resort line, okay? This is going to be for your cardiac arrest meds and things like that. This is going to be your standard infusion port. This is going to
If
be
you
your
have
blood
clotting, which can happen pretty easy on those, is it better
It's a
to
16
try
gauge.
to force
It's
it,
not really-
or would you just replace it?
Don't force anything.
Yeah.
Don't force anything, just like a standard IV. So if there's something in here that's clotted and you force it, it's going to find the path of least
You're
resistance,
pushing a big clot,
and you're
right?
pushing a big clot. Yeah. So the way that these work, they do.
Oh yeah.
I've seen them do it. Okay, so right now there's air in here, and there's your fluid. I mean, barely anything. So that's a small,
Yeah.
right? And you see the pressure that,
Yeah, yeah.
I barely touched that.
Right.
You see the
Yeah.
pressure that came out of there, right? So don't,
So
when you're
Don't
pushing
what
hammer
you're
it.
saying
Well,
is
I
if
mean,
you
just
really
A
are
slow
pushing on
push
it,
will be fine.
yeah, I mean, go ahead, push that gently.
Look at that paperweight.
Yeah.
It doesn't take much,
yeah, we want to get credit for that.
right? It doesn't take much.
Yeah, so if you really are pushing on it, you're creating a lot of pressure.
The nice thing is that they could realistically have blood being infused in one port. They could have, something else being infused
Medication,
in another
right.
Do
port.
you have another? Do you have another line?
Like a what? Like another flush?
Yeah, well, no, give me an empty 10 cc if you have it.
I'm sure we got
Oops.
one in the right.
I'm sure we got one here too.
We, at a couple of the other agencies that I work at, we see a lot of
We need to turn them all
dialysis
straight right here.
that have so poor
Just one sit right here.
access
Thanks.
that they have to have these ports.
Just
So,
saline. Cleaning the
Was
carpet.
that in a? Was that in a wrapper?
No.
No.
Why you need it? That's crazy. What happened?
It was in a wrapper, or was
No.
it? All right, because I'm gonna pull.
Oh.
No, I'm not gonna drink that again.
Helen
So I
wanted,
wanted at least one sip. of it.
Helen wanted a coffee IV earlier. Lay down, Helen.
You don't mind, right?
So, Trey, go ahead. You were making your point.
No, I'm just
About-
saying, like, it's nice that when you have a central line like this, like, instead of having, like,
You
multiple
don't have to have three peripheral
lines,
IVs. You have
you can have blood going, you can
blood,
have...
fluid, and drugs.
Blood, medication.
Right. So, and the other thing is you can have incompatible meds in a
Right.
triple lumen.
Right, because ultimately they're going into the same.
Right. So right now, this is my blood port, which is distal, comes out of the tip. Right. Okay. And now I can be running. You're going to see it come out of the side of this line. Right now I'm running blood, and right now I'm running meds. See it come.
Yeah.
Oh,
It's coming out
coming
right
up on
here.
the top.
Okay.
Yeah, it doesn't come out at the end, but it still's mixing, right?
Gotcha.
It's mixing,
In a
but
vein.
Same
listen,
vessel,
the
yeah.
turbulence
Vessel,
is so fast and so high. I'm moving 5 liters per minute. That's not going to be a problem. This is
So drug
So it's not like
incompatibility,
you're
you're not
flushing
worried
two
about
meds
with those,
together.
even though it's ultimately going into the same
fine.
I'm
vessel.
saying, like, even if you
very
had two meds that were
similarly close to each
incompatible,
other.
like sodium bicarb's not compatible with a lot of
anything.
anything.
Yeah, it's
So if you've got like a sodium bicarb drip, let's say, that's not compatible with,
Calcium.
So you're saying you can use that you could drip sodium bicarb?
yeah, you can drip it through the other port.
not the same line.
No,
Right.
no, but
You'd
this,
have to-
but in
So
the same
this,
vessel.
this
Can't
could be
piggyback it,
bicarb
but
here,
you
this
can-
could be calcium here, right? So there's my bicarb, and there's my calcium is up even
Yeah.
higher.
So even though it's going in the same vessel,
It's going
It's
through a
not
different
close enough
port.
that it creates an issue with incompatibility.
Right.
Okay.
Okay, so does that make sense
Yeah,
as to why they
absolutely.
use those now? And these can be placed as PICC lines even, so that they can stay in place for long periods of time.
There's actually, every time they change the protocols or update them, I know that they really talk about adding central lines into pre-hospital for emergency vascular access.
Here's the
It
issue.
never
I
happens.
don't- Here's the issue. If I access your subclavian, when I get into your subclavian, what I'm doing is I'm following the angle, right? And as I'm
drawing.
pulling back, I'm going to get a flash, and it's going to be a big flash when it gets in there,
Big
right?
dark one, right?
Yep. And that's what I'm looking for.
Just like when they're putting a femoral line.
Same thing.
problem
They're-
is
you're
that
gonna
they
get a
go
big
with,
sticking.
they go with the least common denominator when they're making decisions
The,
like
the
that.
bottom 2% of paramedics, they don't want doing this.
Well, I think it's more than 2%, but anyways, I mean, they had a guy last year, they did a humoral access for an IO, and they went through a clavicle.
Yeah. It happens.
It's not even-
Stuff like this happens all the time. It does.
I get
It
that.
does.
Mid-clavicular humoral access.
So
Dr. Daly showed me the x-ray.
Yeah,
I
I've
guess
seen the
what I'm
X-ray. I
really
saw that
what I'm
X-ray.
really getting at is,
It happens. It does. It's-
other than
That
there's
was
a
here,
little bit of
like,
an extra
our region.
procedure
Mhm.
Not here,
for
but-
placing it, what are the other
No,
risks?
It's the risk is extensive when you're talking. So when you're in the
Right.
neck, you're talking about
Very close, right.
you're in zone
Right.
1 when
Yeah.
you're putting one of these in.
Little
So
confusing.
6 inches.
You know, if you hit the wrong
Shoulder.
vessel,
It
you're in
needs
an
to be
artery.
cleaned
Yeah.
You're
appropriately,
in
and
an
you're
artery
prepped-
instead of the vein.
right.
Okay.
That's
And that's
stuff
the
they look at when they're
That's a
making
problem.
decisions like that. They're
If
never
I
gonna
go
allow us to
through
use
the
central lines as long as we've got IO.
subclavian,
You got a bunch of.
But, you know, this.
I've got all the
possibly
great vessels,
hemorrhoid.
right? The
Yeah,
innominate, the
hemorrhoid.
subclavian, and I also could hit that lung and
Yeah.
drop the lung.
Right.
Now, if I don't
Same reason why
recognize that I hit pleural space and I start infusing, I just infused a bunch of
You're
fluid.
creating a hemo that's not
I
blood.
remember when
hemo.
EJs were
It's not,
everything.
yeah, I mean, it could be
Yeah.
even worse than
Fluid
that.
still
It could be a
yeah.
chemical
Right.
insult. I mean,
Line,
you know,
but
so it's,
It's not.
IO is so fast and easy.
Right.
right? So,
Yeah,
yeah,
and
that's the
with
thing
the
is,
new IO.
IO is fast and
To do
easy,
that
that's
when you
why
could
we
just
use
hit
it.
the shoulder or the
So-
tibia.
But then
Question-
again, you look at IO. You know, they just did it at Fulton County. Somebody put an IO into the patella.
Awesome.
I heard about
It's fabulous.
Questions on how this type of device works? Questions on how this type of device works? Okay. So what I,
Can they send, just a quick, can they send that off a generator? I mean,
send it off.
Kind of like capped, not
train,
working.
yeah, capped off just like that. I mean, they're gonna
Would they
want to
replace
they're
it,
gonna want
not
to be
give us the
pacing this
generator?
patient,
Oh yeah,
obviously.
yeah. No, they
But-
can send it like that.
If they decided that they just have it in place,
Yeah,
the
yeah.
patient's
In
improving,
case
and
they
they don't
need it
need
or
to
what-
do
yeah,
it,
absolutely.
we can just
They'll
send
place
They're
it
not gonna-
prophylactically.
And a pacer they won't float prophylactically.
But they
for
could have
third-degree
been
heart
pacing
block-
and then they not needed it anymore and they won't withdraw it.
If they're pacing a third-degree heart block with this, it's going to be pacing the entire time you have it. They're not going to turn that off. They'll leave it
And
on.
if they don't need it anymore, they'll take it. They'll pull it.
They'll pull it before they go. They'll have a standard. I don't have a standard Swan-Ganz catheter, which is just the catheter. It's like this
Yeah.
with this
Without a
bulb,
pacer in it. Yeah.
without the pacer.
So how does that hook up to the pacer?
Right here.
It plugs in.
Yeah, but it plugs in,
Never see like a little generator box.
but it wouldn't go
It looks
on
like a
our monitor,
voltage
so-
meter, actually. The one that
You
I've
can,
seen,
you
right?
can.
That has
It's
a
like a little
voltage meter.
voltage.
Like he says, you can get like
The
a
little alligator
module
clip
for the
something.
LifePak 15 where it would have cables that came off the other end that would plug into this.
Right.
And then
And
you'd have,
And it knows it's not obviously externally pacing. It uses the correct amount of.
and then you
I'm
can
Which
set
is
all
sure
a
you
that.
can
very,
dial,
very
I'm sure you
small
can dial
amount
it
of
in just like we do for regular patients.
Here in the
Transcutaneous,
intensive hospitals,
yeah.
you know, they
But
have
much
these
less
little
energy
generator
because
boxes.
you're
Yeah,
right
oh
there.
yeah, because you're right there. You don't have to go through all that tissue.
Almost like what they
to
hook
get
up
it.
to like,
It's like what physical therapists
yeah,
use.
like exactly.
Like a TENS.
And there's all kinds of different adapters for just to go over back to the PA catheter, because that's going to be sutured. This is going to be sutured in place. This is going to be sutured in place as well.
Okay.
So just be aware of that. So there's different types of adapters. Like these adapters go right over the top of this. So to answer your question, once it's in, they're going to leave it because they know that it's touching the exact spot where they got capture. If they don't need it, they're going to leave it there in suture. Right.
We see a lot of regular Swan-Ganz without, the pacer
Without them using
inside.
it,
Yeah,
right.
it-
It's just there. Yeah. Usually, I mean,
that gives them
anytime that you
direct
want-
access if they need to put that in quickly because they can
What-
feed a pacer into an existing Swan.
Absolutely, and that's once the sheath is in, once the introducer is in, and I'll leave these here with you guys too. But once the introducer's in place, it stays in place. So, and I'll leave this stuff with you guys.
That's a sterile procedure, right? For
All these
for,
are sterile
yeah,
procedure.
That's
Actually,
done by usually one of the cardiologists.
diagnostic imaging, ideally, or under ultrasound. But I mean, yeah, I
Yeah,
mean,
how
look
they
at the
normally
size.
place
Look at the
the
size of the
The
drapes.
drapes, right?
This is their full body.
Yeah.
You know, so it's
Now
completely
where
sterile.
this isn't something you're going to see them be doing in an emergency room. This is an
They
admitted
could.
patient.
No. We do this in our ER now.
Yeah.
We float pacers all the time. That's one of the reasons why we have a ROS grade like we do.
Oh yeah.
Our ROS grade,
You gotta hear this.
yeah. So,
I'm sorry, I didn't hear where you were.
I'm the director of professional development at Bay State.
Okay, good.
So Bay State Noble is a teeny tiny little hospital, and because we're able to like really kind of move everything the way that we want, we just acquired them. Probably shouldn't. We should probably delete that. But anyway,
Yeah.
we just acquired them, and I've had the opportunity to work with them. So the first quarter that I was there. Now this is ROS rate for all patients arriving to the emergency room that either arrest in the ER or come in full-blown arrest in the ER. So it's witness, unwitness. It's not VTAC, VFib. It's VTAC, VFib, asystole, PEA. I don't care whatever you are. You're pulseless. This is a ROS, right? We started at 7%. The national average is 11% pre-hospital. Pre-hospital is always higher than in hospital because by the time they get to the ER, it's over, right? So we went from 7% to 14, not bad, to 27. All arrests, all postless arrests, 27% ROS rate.
And part of that is
50% discharge.
because of the
aggression,
aggressiveness and advanced procedures.
The aggression, the advanced procedures, but it's actually because we've gone way back to basic. We don't do
CPR.
advanced airways. We don't do Kings. We don't do any of that stuff. We do BVM. That's it. If they come in and they've got a King in,
It's working.
we deflate it and we pull it.
And like a 30-degree heads up too.
We do 30-degree heads
Yeah.
up because it decreases intracranial pressure, which allows you to increase cerebral perfusion pressures with lower systolic blood pressure. So we do that.
Which all
immediately.
started coming from head injury patients. And
Yep,
finding
yep.
that
Absolutely.
decreased pressure is good.
Pretty interesting.
So when that's in place, it stays in place, right? This is how you can float stuff through there. So it just becomes a sheath where you can.
So that's kind of sticking out of the, at some point, that's sticking out of the skin to some
Yep.
extent. And
Yep.
Wait, what
When
is that?
I'll leave this. So this is an adapter.
Oh,
So once it's in, it can stay in,
oh,
and you can
okay.
float different things through it.
Gotcha.
so once you know you're placed,
Yep.
Mhm.
And you can see
In
the
the
size of the
subclavian.
inducer for that.
Okay.
It is. It's
is
a
that like
giant.
10 gauge,
7.
7 gauge.
Jesus.
You don't want anything that big sticking out of your skin.
And that's giving you direct medication access to the heart, right?
Oh.
Yeah. Oh, okay.
Like
So
instantly, like they, because they always say
I gotta
a
go for that.
humoral head thing is
I don't-
1.8
Yeah, I just started
seconds for
using
cardiac
those
meds to the
more
heart.
now,
To the
forcing
heart.
myself.
This has got to be
Yeah.
instant. The minute you push it,
it's
in.
about the same as the
Yeah.
humeral head. It's
Oh,
not any
really?
faster. So, but there is one important thing that I'm going to leave this here with you guys too, so you can play with it. One thing that I do want to make very, very clear: if you have a patient that's in an SVT and you're using a subclavian line, okay, you can push your standard dose, 6 milligrams of adenosine. Okay, they are going to stay down for a long.
Because you're saying because it's so direct that
It's
it's
right there.
You're not getting the
Right.
delay.
When we push adenosine in the ICU through a central line, we push 3 milligrams.
So you're not smacking it so long, and the break in conduction is not so long.
So just be aware of that that drug is in there immediately. So
So they're
and
asystole for 10
you
seconds.
guys still do RSI too, right?
Oh yeah.
Yeah. So just be aware of that too.
So you're
it's
giving
part of
paralytics
your
and
part of
sedation
your
units.
like minute and a half in a poor perfusion patient when you're giving succinylcholine or
Waiting
whatever
for it
is
to
because you're
take
waiting
effect.
for it to circulate,
Yeah.
right? But this here, it's like, okay, it's
So they're
in.
down.
Standard dose
Yeah.
still though?
It's standard dose, but just be
It just
aware it's
happens
gonna
much
this
faster.
stuff's gonna work much faster if you're going through subclavian or IJ because it's right there. Femoral's gonna take a little bit longer, but not a whole lot. Okay,
It's like that rapid,
It's still in a big
rapid
artery.
flush out, you know what I mean?
Yeah.
big vein.
Big
Right there.
Which is why when you're giving like adenosine and that stuff peripherally, they're saying it's a fast push with a big flush behind it
Yep.
because they're trying to get it to the heart.
Mhm.
People don't like adenosine.
No.
No,
Well,
Some
If
because
they're awake, they
no,
don't.
they're experiencing asystole.
Some
Yeah,
people will
it's
tell you
it's
they're
not a good
allergic
place.
to it, even though it's like normal.
Well,
Yeah.
I didn't
Everybody's
Yeah.
allergic to
Take
it.
Right? You
why?
know,
What
someone's
happens
body.
when you take it? Well, it
I
stops my heart.
die.
Well, no shit.
I didn't hear what saying or
I'm really allergic to it.
You're
It stops my heart.
You're okay.
They'd rather be electric.
So no
Yeah.
questions on the actual line. So what I want to do is I'm going to go over the standard physiology like I did on. Let's go over just the standard hemodynamics, and I'm going to do the definition. So cardiac output we already talked about, right? So cardiac output is the amount of oxygenated blood that you move every minute. So the average is 4 to 8 liters per minute. When we're looking at that, it's always the heart rate times stroke volume equals cardiac output. Stroke volume is the amount of blood that is pumped every time the left ventricle collapses. So that's the amount of blood that actually comes out of the ventricle on pumping. When we talk about the preload is the diastolic filling pressures. That's a stretch of the myocardium at the end of diastole. The afterload is the aortic pressure amount of the pressure. It's the amount of pressure that it takes to push blood forward out of the ventricle. Starling's law means that if you stretch myocardium, it'll snap back. The more that you stretch it, the harder it snaps back. Okay? Contractility, we all understand what contractility is. That's the amount of squeeze. We talk about inotropy, that's contractility. Arterial pressures, we already had preload, afterload, systolic, diastolic, and mean pressure. So the most important one to understand out of this is mean arterial pressures. The way that you get a mean arterial pressure is this. On the machine it says MAP, that's your mean arterial pressure. If you don't have a machine that gives you that, it's systole plus diastole plus diastole divided by 3. So systole is squeeze, diastole is rest, rest. So it's, let's say 120 on 80. You're going to have an MAP of 93. I suck at math, I memorized that, okay? So, but if you do the math, what you'll get is you'll get 120 plus 80 is 280, divided by 3 is, should be 93. I think I memorized that right. So it's 93-ish, okay? So MAP is important. Any MAP that's above 60, you should have a ROSC if the patient's in cardiac arrest. Any MAP that's above 45, you should have a ROSC if the patient was in cardiac arrest. If you can get between 30 and 35, you've got a decent shot at a ROSC. So that's what we shoot for, is an MAP of 30 to 35 for all of our arresting patients. All right, so the study of blood flow and the forces creating it. So when we talk about cardiac output, that's the amount of blood the heart pumps every minute. Stroke volume is the amount of blood that gets ejected with each collapse of the left ventricle, and contractility is the force. Preload is the diastolic filling pressure, and afterload is the amount of pressure the ventricle has to overcome to push blood forward. Starling's law we already talked about. Stretch, stretch, stretch. The harder you stretch it, the more it snaps back. It's like taking a rubber band. The more you pull it, the harder it snaps back. So when we're dealing with patients that have right-sided infarcts, right, we never want to take fluid away from them. We decrease their preload, you kill them. The problem with decreasing preload is you decrease afterload, right? So here's the issue with the inferior wall MI. Most patients who have an inferior wall MI, right, it's what coronary?
Right.
The right coronary. The right coronary goes to the right side of the heart. When I asked you guys earlier, where's the SA node?
Right.
It's in the right side of the heart, right? What's your SA node control?
Heart rate.
Yeah, your heart rate. It's actually the most dominant pacemaker, right? So it's atrial contraction, but it's also the most dominant pacemaker, so everything else follows it. So what happens if my heart rate drops, right? Because that's what happens when you have a right-sided MI, right? Because why? Because you're not getting oxygen to the SA node. So the SA node says, I don't want to do this anymore, and it's going to slow down. Because if I work too fast, it's going to extend my MI, right? It's going to consume more oxygen. So now I take away the preload, right? Which means that what? It means my stroke volume is going to decrease because that's part of the afterload, right? So if my heart rate goes down, my stroke volume has to go up in order to maintain cardiac output, right?
In theory.
In theory it would, right? So if my stroke volume goes down, what has to happen to my heart rate in order to maintain cardiac output? It has to go up. But now it's ischemic. The SA node's ischemic, and you're saying, all right, well, we're dropping your preload, which means I'm dropping my afterload. What's going to happen to your heart rate? It's going to try to go up. And what happens? They extend the MI, they die. Okay? So that's why we always got to give fluid to a right-sided MI. Because if you don't, and you don't get that added stretch, you're not going to get the contractility, and your SA node's going to get beat up even worse. Okay?
Well, Dr. Delaco used to say that these patients that came in with, or have, right infarcts, that we should be giving them 5 to 6 liters of fluid.
Oh yeah. In the first couple hours.
Really?
Like the first four or 5ve hours are the most critical.
They said they would give like a 500 bolus. I'm like, do you know what that's doing? That's like
yeah,
a cocaine.
It's spit in the ocean.
Yeah.
It's not much. It's not much. I've heard 5 to 7 is kind of the standard for
liters.
some cardiologists. Yeah, 5 to 7 liters. Yeah. And that's just going to increase your preload, and it's going to increase your contractility, and it's going to tell your SA node everything's going to be all right. You don't have to go crazy. All right. So systemic, I don't know why there's a W on the end of that. Systemic vascular resistance, that's the amount of resistance to arterial blood flow. The way we get SVR in a patient that's in cardiac arrest is what? What do? Resistance to arterial epinephrine, right? Those kind of drugs. That's what we're looking at to increase SVR. Arterial pressure, systole is the highest pressure occurring during ventricular systole, during the squeeze. Okay, diastolic arterial pressure is the lowest part of the pressure curve. That's when the ventricle's at rest. And then the mean is the average pressure present in any particular chamber at any time. So again, cardiac output is heart rate times stroke volume. All right. Mean arterial pressure is 2 times the diastolic plus the systolic divided by 3. Need an MAP of 60 to 70. That's to adequately perfuse the brain and the kidney. We know that at an MAP of 30 to 35, you're in profound shock, and that's enough to perfuse stuff for a gradual amount of time. You guys have heard VQ for years and years and years, right? VQ mismatches, VQ scans and things like that. So if I have a PE, they send me for a VQ scan. So when we talk about VQ, Q is perfusion, okay? Q is perfusion. V is ventilation, right? So if my heart rate's 100 and I need to breathe 20 times a minute to feed that heart rate of 100, right? Okay, to maintain normal stasis, then what happens when my heart rate drops all the way down to 20? Ventilations are still at 20. Well, that's no good. I got too much ventilation, not enough perfusion. That's a VQ mismatch, right? So when you're in cardiac arrest and the heart rate goes to 0, ventilations go to 0. I come along and I start doing compressions at 100. Cardiac output is very, very small because I'm only moving a tiny amount. I'm only moving 10 cc's every time I pump on that chest. Then that means I only need to ventilate 10 times per minute, right? So you're trying to match V to Q all the time. Now when you start to get a ROSC, you have to raise the ventilations up, okay? So that VQ match is super, super important. And we know that if you can get an MAP of about 30 to 35, somewhere in that range, you're doing pretty well. You actually, you will get a ROSC, and then you'll have to match the ventilations to it. All right, so we kind of talked about this, change the cardiac output with the heart rate. So again, increased heart rate. So let's say my stroke volume is 70, I get on the treadmill and I start running. I'm gonna produce lactic acid. I have a higher oxygen demand, right? So I need to take in more oxygen. So I'm gonna breathe a little bit faster, okay? And my heart rate's gonna go up. My heart rate goes from 70 times 70 heart rate, 70 stroke volume, 4,900. I get on the treadmill and I run and I run and I run, and my oxygen demand goes up and my heart rate goes to 100. I'm still pumping 70 cc's every time. My cardiac output is 7 liters, right? Okay? So that's how you increase heart rate to increase the cardiac output. You can do that pretty easily, okay? So when we talk about what increases, decreases, it's all right here, okay? So if you have an increased myocardial O2 consumption, that can actually decrease cardiac output. You have to match it somehow. That's why your heart rate goes up, okay? The thing that's interesting is adults can do all of this stuff. Most kids can't. Most kids are super, super heart rate dependent, and that's it, okay? And the smaller they are. So under a year, they're all heart rate dependent. They can't increase their stroke volume like we can. They can't increase their systemic vascular resistance, none of that stuff. They can't do any of it, okay? Heart rate is determined by autonomic nervous system, sympathetic and parasympathetic receptors, baroreceptors, chemoreceptors, and metabolic demands. I have a fever, right? I have an increased metabolic demand. What happens to my heart rate? It goes up. I got to get more oxygen into the tissues or I'm going to go into shock. Okay? And that's how sepsis happens, essentially. It's not getting enough oxygen to the tissues. All right. Okay, preload, blood's just sitting there. Afterload, it's being pumped. Simple enough. Okay, so pulmonary circuit. This is important to understand. Low pressure system with little resistance to blood flow from the right ventricle. Okay? The systemic system is a high pressure system with higher resistance to left ventricular outflow. What does that mean? Low pressure circuit. The lungs are soft, the lungs are spongy, it's low pressure. It means that it doesn't take a lot of pressure to push against them. So anytime that you do get increased pressure, it makes the right ventricle work harder. Where would you get increased pressure in the chest if you had like COPD or something like that, right? So you'll see that the right ventricle will remodel and get larger, okay? You might see the right atrium get larger. When we're talking about the left ventricle, okay, it has to pump. Think the right ventricle is right here, it only pumps blood here. That's it, boom, boom, okay? The left ventricle pumps blood where? all the way down there, all the way up here, everywhere else, right? So the left ventricle is always thicker, it's always bigger, and it always does more work. And it pumps to a higher resistance consistently, and that's why it's a thicker ventricle. And when you look at the left ventricle, when patients have cardiomyopathies of the left ventricle, it's typically because they have what? A higher pressure system than what they should. So what would that be? Like when you're diabetic and you have hypertension, those types of things, you got to pump against a higher pressure, then the left ventricle is going to get larger. Okay? So these are all things, whenever the ventricles get larger, but they're not more effective. It's because they're pumping harder, right? They're pumping against more resistance. So the problem is that that can predispose you to cardiogenic shock. So anytime that you have an underlying issue with like hypertension or any of those things, you can end up in cardiogenic shock if you have anything go wrong in the system. All right, so the valves look like this, right? And they should close all the way. Okay, so your aortic semilunar valve, your pulmonary semilunar valve, your bicuspid, right? And your tricuspid. So, what ends up happening is these valves slam shut and you hear lub dub, lub dub. That's the closing of those valves. Okay, the right atrium. Systemic blood returns through the vena cava and it flows through the right AV valve into the right ventricle. The right ventricle, normally the pulmonary bed offers little resistance to it. Okay, so when it does offer resistance to it, you guys have heard of systolic murmurs and diastolic murmurs. Everybody's heard that term? So a murmur is what? It's an extra heart sound, right? So S3, heart sound, is a diastolic murmur. And you don't hear lub, S1, dub, S2, murmur, S3. What you hear is lub, murmur, dub. You guys all know that. S3 shows up in the middle, right? Okay, so why is that? So, just this system alone, the easiest way to explain this. I get a lot of fluid in my lungs, right? So I'm going into fluid overload. And the fluid starts to back up down into the right ventricle, right? The right ventricle is usually pumping to a low pressure circuit. Now it's got to pump against a high pressure circuit, okay? Everybody's on board still, right? So normally low pressure, now it's high pressure and I'm pushing fluid back. The right ventricle is trying to push against that. So it pushes the fluid the best that it can, it moves some of that fluid forward, and then that fluid pushes back. When it pushes back and it overfills the right ventricle, okay, because of the high pressure, what it does is this right here. It goes back up against the valve, and the fluid goes into the atrium again. Does that make sense? So what you're hearing is lub, dub, okay? So lub, it's pushing the blood forward, right? And you're hearing that valve close. And now, murmur, dub. Pulmonic and aortic are dub, right? Okay? So what you're hearing is too much fluid, regurgitation. You also hear it for an incompetent valve, if there's vegetation or something like that. So an S3 is lub, murmur, dub. Lub, murmur, dub. And you know that before you even see neck vein distension, because it's taken time to get to the neck veins, before you even see that, before you even see it on the x-ray. You can see it on echo first, but you'll hear it as an S3 before you see any other symptoms, even higher blood pressures.
Now, would that eventually lead to S4, or is S4 just a whole separate thing itself?
It's the opposite valve, but you can hear S4 sometimes in combination with that over time, gradually, but usually it's a different reason that you'll hear it.
Usually first is an
So
S4.
what are you
It's
saying? It
usually
sounds like
first.
a balloon deflating?
What's that?
You said it sounds like a balloon deflating?
It's like a purring. You almost hear, it's like a cat purring is the way that it sounds. You'll hear a lub, murmur, dub. So it's like lub, dub. Sometimes it's just short, sometimes it's longer. But that's a diastolic murmur.
So we'll hear that in pulmonary edema then? Like,
Typically you'll hear it in pulmonary edema because there's so much fluid it's backing up. You'll hear it long before the pulmonary edema. You'll hear it when it's just standard CHF, unless they flash, right? Then that's a whole different ballgame.
It's like part of your chest auscultation when you're doing your differential diagnoses and is this pneumonia, is this failure, you should be listening to heart sounds as well.
Right, and if you hear that
Most
heart
people
sound, you're thinking more along the lines of putting it together with other parts, components of this is failure versus pneumonia. And then Jay also mentioned that S4 is at the very beginning. So what is that when we talk about lub-dub? It's before the lub. It's actually when you hear it coming back through the pulmonic
It's
or
not the
aortic.
same, like the purring?
It's a purring at the very beginning. Yeah. All right, so the right atria, we already talked about this. The left atria, it passively empties oxygenated blood, so it's gone through the lungs, gotten oxygenated, via the 4 pulmonary veins through the left atrioventricular valve into the left ventricle. So the blood has just come back, it's oxygenated, and it's sitting up here in the left atrium. Now, your atrial kick is only 30%. Okay, so like if you go into AFib, right, instead of that thing pumping, you're going to lose 30% of your what gets expelled out of the atrium. That's why we worry about patients developing clots who are in AFib, because the blood's just pooling there. Okay. The left ventricle, high pressure is required to overcome the systemic circulatory resistance and send blood through the aortic valve. So, when you hear issues with the left ventricle where there's increased pressure, okay, like aortic stenosis, you're going to hear what we call a systolic murmur. So what happens is this. You guys have all, if I'm using a hose to water plants right here, right? I don't have to put my thumb on it. I can just spray it, and it makes almost no sound at all as the fluid's going through the hose, right? If I want to send that water further away, I have to do what? I have to reduce some of the lumen of the hose, right, in order to create more turbulence to send that further, okay, which is not necessarily a good thing. It can weaken the walls of the aorta over time, weaken the walls of the hose over time. And I hold it like this, then you'll hear what in the hose? Higher pressure, right? So, lub, murmur, dub, murmur, right? That would be your S4. At the very, and it sounds like it's at the very beginning, even though it's at the very end. It sounds like it's at the beginning of every cycle. Lub, dub, murmur. Those are diastolic. Systolic murmurs sound like the little old lady who's got AFib and aortic stenosis. Whoosh, whoosh, whoosh. You'll hear that. You don't really hear lub, dub anymore. You hear that whoosh, whoosh, whoosh sound. And that's under higher pressures because there's a lot more resistance. So that's one of the other things that we look for. Now, if you have an incompetent valve, lub, dub, right? Or you have that whoosh, whoosh. When you're floating these catheters, you can run into trouble. Simple enough, okay? So just be aware of that.
You want to be cautious with the fluid too.
You have to be extremely cautious with fluid. You have to be extremely cautious with medications and titrations. You have to be extremely careful whenever you're floating a PA catheter, whenever you hear any type of murmur. All right, so
Even people that have had like aortic valve replacements and so forth, I'm still cautious with giving them both boluses.
oh, absolutely, absolutely, absolutely. You have to be. You have to be. Okay, so back to basics. I'm just going to talk about the basics for intra-aortic balloon pumping, and then I'm going to skip past some of that stuff. Early diastole, the valves are open, blood enters the ventricles. It's passive and rapid. Late diastole, the atria contract, providing ventricles with an additional 30% blood flow. That's the atrial kick we just talked about. Okay. Systole starts with the closing of the valves between the top and the bottom of the heart and ends with their opening. Okay. Early systole is all this other stuff. It's called isovolumetric contraction. That's what it looks like. Okay. When are the coronary arteries perfused? During systole or during diastole? Diastole. So when you're at rest, right, the blood backs up through the coronaries, okay? It doesn't really get pushed back except for whatever systemic vascular resistance you have. So think about it. If you're in cardiogenic shock, what's happening to your blood pressure?
It's going down.
It's dropping, right? So what's happening to your systemic vascular resistance? It's going away, right? So how well is that blood going to get pushed back through the coronaries?
Not very.
Not. And if you're hearing a murmur, right, how well is it getting pushed back through? It's probably at a higher pressure, but we don't hear a whole lot of S4s, we hear a whole lot of S3.
Depends on how much levothyroxine.
Yeah, exactly. All right. Okay, so here's what we're looking at. During diastole, during rest, the driving force is absent, but passive blood flows continues because of the elastic properties of the proximal aorta. Okay, so it's all important that all of this stuff is normal size and it's all important that like the left ventricle is normal size, the aorta is normal size, it's not narrowed, it's not obstructed, it's not too wide. So during diastole, blood comes back and it goes down into the right coronary and into the left coronary, all right? When there is a decreased O2 demand, constriction occurs resulting in a decrease in O2. That's going to be interesting to talk about here too. All right, reduced myocardial oxygen demand and increased coronary artery perfusion. Those are the goals of the balloon pump. We want to reduce the amount of oxygen that you're demanding, right? So we want to control your heart rate. We want to control your stroke volume, right? And we want to increase your perfusion. We want to basically augment your systemic vascular resistance, which you can do with drugs too, okay? So the goals are reduce the myocardial oxygen demand and increase perfusion to the coronaries. And I know that you've got somebody who's going to be talking more specifically about this, so I'm going to make this as simple as I can. So the balloon insertion, it's surgically inserted with a cut-down technique, more commonly inserted percutaneously through the femoral artery. Okay, so what it looks like is it looks very similar to something like this here. That's all right, you don't need to. It looks very similar to something like this here, okay? And what they're going to do is it's going to go up through the groin, right, through the aorta, the lower end of the aorta. You don't want it too high. So you don't want this to obstruct any of the arteries either. So there's a certain landmark that they use for this. Now, remember this little balloon at the very end, right? That little balloon right there? Well, imagine that this whole thing is ballooned. It can inflate all the way up, okay? So what we're going to do is we're going to insert it, and we're going to thread it up, just like so. Okay? You can see here, they're using the guide wire through a tortuous atherosclerotic vessel. That's why it's so important that we've got clean vessels to work with. But we're going to use this wire to float it. And you can see there's the balloon, there's the balloon. You see how it's the whole thing can inflate, right? And the balloon is advanced over the guide wire and passed retrogradely to a position just below the origin of the left subclavian artery. Right here is the left subclavian artery. Okay? So you have your innominate, you have your IJ, and you have your subclavian artery. The balloon is going to come right to this point here. You don't want it to be up here because if it inflates here, it blocks blood flow to the brain. Okay? So you want it to inflate right here.
How do you know? I don't know why they keep passing it out.
Pass out. How do you know where it is? You're going to take a picture of it as well. Or you can do it under fluoro, or once it's in place, you check the timing, you check the response of the patient, and then you get an x-ray of it. You do it right at the bedside. Okay? So after the guide wire is removed from the inner cannula, you set up the pressure monitor. Anytime that you guys use a pressure bag, it's always going to go to 300. Okay, so pump it to 300. Okay? Transducer setup, level and zero. All right? Always level it, always zero it. And I'm going to come back to this in a little bit. But when we level it, what we want is this area right here. We want it at the phlebistatic axis. Why there? Because that is the approximating location of the right atrium. You want this thing to be at the level of the right atrium. So, and it's the right atrium when you're laying flat. Because if I sit you up to 45 degrees, I've lost my waveform. I lose my my leveling and my zero. If I zero you on the ground and then I take you to altitude, I have to redo my zero because it's at a different pressure. So if I'm at 5,000 feet higher than where I was when I first zeroed it, I got to zero it again. Okay. In the balloon pump world, any transducer. Okay, so these are just standards for any of these types of lines here. Keep the tubing length to a minimum. Make sure there's no entrapped air or blood clots, even like we did with the chest tube. Stiff, non-compliant tubing is used, so it feels fairly rigid. Okay, and eliminate any loose connections. So you're going to make sure that everything is tightened down. So they have things that they call dead end caps. You guys have probably seen them. They're the little blue. They're just blue or white caps, right? And when you put those on the end of these, you want to make sure that on any of these fittings that there's something on it and it's locked in place. Okay, you don't want anything open to air. Okay, the fast flush test. You're going to do it on the initial system setup, which you guys aren't going to worry about. But you could do it after blood withdrawal, which you guys aren't going to be drawing blood in the field anyway. But you can use it for troubleshooting, and it's at set intervals. It's typically at shift change, so it used to be at 8 hours. And basically what you're doing when you do a fast flush test, they're flushing fluid through there to make sure that it's still in the right place and to make sure that it's still measuring. Because what happens is there's a little transducer, there's a little heat sensor, and as you flush cool fluid across it, it's cooler than your blood, it picks up the gradient and it reports back how fast it's moving through the catheter. That's all a fast flush test does. All right, so I'm going to show you just the basic waveform. Don't get too wrapped up in it, okay? This is atrial systole. Semilunar valve opens, you get your contraction. Ventricular ejection phase is right here, and then it relaxes right here, and the semilunar valve closes, okay? That ties together with this right here. So if you look at this again, right? Atrial systole. So my atria is kicking, right? That tells me what? There's a P wave, okay? Semilunar valves open way over here, but the AV valve closes right in the middle of this, right? So you've got your QRS complex, your ventricular contraction right there at the same time that this is going on, okay? So your atrial systole is here, your ventricular systole is this phase right here, and then complete rest is this diastole piece, and it correlates with the EKG, and the EKG correlates with this right here. We're looking for something called the dichrotic notch. That's how we do our timing. Okay? So what that means is this. Okay? So don't even look at this for right now. My atria contract. I don't care. My ventricles contract. I care. Because the left ventricle pumps blood where? Everywhere. Into the brain specifically, right? So the left ventricle has to pump blood to the brain, right? So I need to know that piece of it, okay? So when the left ventricle pumps, okay, I want to augment the amount of blood that comes out of the left ventricle, right? Because if I take more blood out of the left ventricle, what does that do for my heart rate? I can lower my heart rate. If I lower my heart rate, what happens to my oxygen demand? It decreases as well. So I'm not going to extend my MI. Does that part make sense? Okay? So when my left ventricle collapses, what I want to do is, if I can increase my stroke volume, right, then I can theoretically do what? Drop my heart rate. Less oxygen demand, less extension of the MI. Yeah? We're good? Okay? So, how do I do that? I got to create a vacuum. I got to vacuum stuff out of the left ventricle, right? Okay? Now, the other part of it is that we were saying if you lose your systemic vascular resistance, your blood pressure is low, you're in cardiogenic shock, right? I don't have much pressure pushing back, which means that that oxygenated blood that just came out of the left ventricle, right, that's going out through the aorta, doesn't really come back down through the coronaries. So what I want to do is what? When the ventricles collapse, I want to pull blood out of the ventricle, but when the ventricles relax, that's my rest, that's my time to oxygenate the coronaries, right? So now what I want to do is, I want to push blood back up in there, push it back, right? Systemic vascular resistance. So I want to augment my systolic pressure and augment my, basically the amount of blood that goes down through the coronaries. It's oxygenated. So how do I do that? Well, I figure out this dichrotic notch, and that's my inflation marker. Inflation means the balloon inflates, okay? When the balloon inflates, it's pushing blood back. So the balloon inflates at ventricular rest, augmented diastole. It's pushing oxygenated blood back through the coronaries, okay? That makes sense? It is. And the ventricles now are gonna collapse, right, and pump forward. So when they collapse and pump forward, what do I want the balloon to do?
Deflate.
Deflate, and suck blood out.
So it's
So by
creating a
deflating, I make a vacuum. By inflating, I make back pressure. Go ahead.
No, I was just,
Walking it through.
yeah,
Does it make sense?
yes.
So the dichrotic notch is basically my marker to tell me, okay, time to inflate the balloon and give some oxygenated blood back to the coronaries. So your diastolic pressure, right, is usually whatever it is. Augmented is going to change it. So when the balloon inflates, you're going to have a different diastolic blood pressure. So and you see here how. So we just talked about all this. I don't want to get into all this piece here because it can get confusing. Okay, but we can also measure this on the atrial waveform, and we can see what it looks like. Okay, so here's deflation. So what am I accomplishing when the balloon deflates? I want to do it when the ventricle is pumping. I'm making a vacuum and pulling more blood out of the ventricle. When the balloon inflates, what am I accomplishing? I'm pushing blood back up through the aorta and into the coronaries. Okay? Same thing here, same thing here. Here's my balloon deflated. There it is deflated. Okay? Here it is inflated. And you notice the dichrotic notch right there, that's my marker, inflate the balloon. And you notice that it's not occluding any of the great vessels. It's right here and it's right here.
So with the balloon inflating and deflating all that time and having all the plaque and things throughout the vessels, do you ever have to worry about throwing a blood clot or
You
things
could.
of that nature?
You can.
Okay.
You can. Anytime that you have a narrowed lumen,
Yeah.
you're going to increase the velocity through there. You're going
Yeah.
to increase the pressure through there, which can shear a clot.
Well, at that point, you gotta like outweigh your chances.
This
to-
guy's going to die. This is cardiogenic shock, which
Yeah.
carries a 90% mortality, 80
Yeah.
to 90% mortality.
Yeah.
So you're doing what you have to do.
Okay. I was wondering if you had to worry about stroke or PEs or anything like that.
Okay? So dichrotic notch, and right there is your balloon. Okay? So we talk about augmented pressures and things like that too. So let's get into that. So trigger select, you can set the trigger based on what the ECG tells you. So you can look at your ECG strip and say, I want to set the trigger based on this. You can set it at pressure, you can set it internal, you can set it on the pacer, you can set it however you want to set it. But 1 to 1 means every time your heart pumps, one balloon inflation. 1 to 1. Yeah, that's not good. This is the one that we use most frequently, though, for transport, right? 1 to 2 we use when the heart is beating so fast that the balloon can't really keep up with it, okay? So that's when the heart rate's greater than 115. And that means that it only inflates every other, okay? So if you're at 115, it's only going to inflate like 70-something times. It's
But
not
the-
math, but it's 70.
But technically, that should lower your pulse rate.
Mhm.
Technically, that should lower your pulse rate.
It'll help. It should help because it's going to increase your stroke volume, right?
Right.
And then 1 to 3 means it only inflates once every 3 beats, right? And that's when I'm weaning you off of it. So does that trigger sensitivity and timing and all? Okay. All right. So blood pressure components are greatly impacted by intra-aortic balloon pumps. Normally systole is the highest point generator. So normally systole is your highest number, right? But this non-invasive blood pressure recognizes the highest point of systole and records it as such. That's the first Korsakoff sound. You can't record blood pressure in a traditional manner. Why? Because there's augmented numbers. Augmented just means assisted, okay? All right. So in the aortic balloon pump patient, the highest sound is the peak diastolic augmentation, not systole. Why is that? Because when you're going into diastole, what's happening? Balloon's inflating. It's pushing that pressure back, so it sounds higher. It's a higher pressure sound.
Mm-hmm.
That makes sense? So instead of the pump pumping forward, it's the pushing back. And if you ever listen to one of these things, you hear it all. It's just gas going in and out of there, but you hear it. It's kind of that sound. And you just constantly hear it. Okay? So basically what you're seeing here is a waveform that's showing you the blood pressures on the side here. And diastolic augmentation is your highest pressure right there. Let's see what that looks like. Okay, so your trigger is the ECG. So basically, this intra-aortic balloon pump is looking at the ECG and saying it needs to inflate based upon what it sees there. The heart rate is 80 beats per minute. the assisted systolic blood pressure is 112. The unassisted is 117. Whoa, what are we talking about? Whoa, wait a minute. All right, so your heart is pumping, right, harder at 117 than it is at 112. Yes? Does that make sense? If you're pumping at 117, that's a higher pressure than 112, right?
Yes.
Everybody agrees with that. So 112 is doing better than 117 when you're using the pump, because you're moving as much blood, actually you're moving more blood when you're assisting it with the pump than you would be if you were unassisted at a lower pressure, which is nice, okay? So your assisted systolic blood pressure, you always want it to go down. Your assisted end diastolic pressure, right, versus your unassisted end diastolic pressures change as well, 44 and 51. Now the thing that's interesting here is the augmented diastolic pressure is actually the highest pressure, because that's when the balloon inflates and pushes everything backwards. So this is all augmented, this is all assisted, this is all pushing blood back. Okay, so that's what we're looking for, is that number right there. We want to see that number nice and high. Okay? The augmented alarm is 120, so this thing would be going off right now saying ding, 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 there's a problem, but there really isn't. That's what we want to see. Does this make sense? How that balloon pump works? It decreases the amount of work that you're doing on systole, on pumping forward, and it increases the amount of work that your body is doing on rest by oxygenating the coronaries, and that's how it takes you out of cardiogenic shock. It improves your pump function. Okay, so basically it does the same thing that dopamine, that a drip of dopamine, that a drip of dobutamine, that a drip of nitroglycerin, and a drip of Levophed, and a drip of nitroprusside, and a drip of Neofed would do. If you could give all those at the same exact time and not rip the patient now, it's doing all that. Okay, and the other thing is it's doing it like this. Okay, I'm going to give you a little nitrate, and now I'm going to take the nitrate away. I'm going to give you some epi, and I'm going to give you some neo, and I'm going to give you some levo. It's doing all that. Okay, now let's do the nitrates again. So it's doing something that is like physically impossible to do in terms of drips, because you'd be titrating like this. Okay, that's what this thing does. Questions?
Long term, what's the purpose of doing this?
This is to buy you time, to get you out of the cardiogenic shock, right? So that's number one, is we want to preserve as much myocardium as we can and get you to the cath lab and treat whatever.
Right, so sometimes they'll go like to the cath lab at Glens Falls, so they'll end up doing their balloon pump and then transferring the patient to the med.
If it's more than
Is it a diagnostic cath lab?
No, it's an interventional cath lab.
And they're shipping people out on?
Yeah.
I believe
They don't do bypass there?
No.
So if they have to do bypass, that's why. That's why. Because if the bypass is if the issue is, let's just say that I have, usually, okay, so the right side we said feeds the conduction system, the right coronary. The left coronary feeds what? The pump, right? The left ventricle. So usually for 100% LAD or 100% LCA, they would send them to the cath lab. Put them on a balloon pump, right? And then send them to the cath lab. And the reason for that is on the left side, right? If you block that left side 100%, you've lost a lot of your pump function. And every time your heart pumps, right, you're extending your MI. So eventually you're going to go, you'll always have mild cardiogenic shock with a left-sided infarct. But you'll also irritate that to the point where you'll get a lethal dysrhythmia, a VTAC or a VFib. So the more gradual the MI is, right, the more like, you can, the narrowing of the coronary artery, you can have about 70% occluded, 75% occluded before you have any chest pain at all. So you're like 3/4 occluded before you have any pain. Okay, so in that, go back to what we were talking about before. The more narrow that lumen is, right, what happens to the pressure in it? It's higher, which means that you're going to shear those clots off, and when they cleave off of there and break stuff, that's when they tear up the inside lining, and that's when you try to make clots, right? Because you're bleeding. So that's where you run into trouble. So if you gradually get to your left coronary infarct, you gradually get there, oftentimes those patients do a little bit better and they don't go right into VFib, VTAC, they have cardiogenic shock. Eventually they'll develop it. For the patient that's walking around and they're fine and then all of a sudden, wham,
They drop that.
those are the ones, right, where, because they've built a tolerance over time up to that 70%. These patients that are walking around that have a fairly clean vessel, like a 50% clean vessel, they haven't gotten to the point where they can compensate, right? And now they blast a clot like that. A lot of those patients just, boom, they drop dead. Their first symptom is VTAC or VFib and they're gone.
But isn't there a special test you can get done that can tell if you have any arteries or anything? I can't remember the name of it.
No, they do, yeah, so even a simple cath. They can do that with a cath. They can do echoes to see what your pump function is. They can do all of that stuff. Sometimes the issue with the sudden death arrest with the VFib VTAC is a channelopathy, where they have a sodium channel problem. But if it's because of infarct, it's going to be a vessel that was fairly clean that just completely occluded. That's usually if it's due to infarct. And this is also, let's go back to the Ross thing that I was talking about earlier. We had a patient that was on their way to the main hospital, right, which is about 15, 20 minutes away from the smaller hospital, and they were headed for chest pain. They were on their way to the cath lab, and they arrested, and they diverted to our hospital because they arrested. And when they diverted to the smaller hospital, the guy went into cardiac arrest, right? We knew that he had chest pain. We looked at that as H's and T's. What's the reason why he went in? Thrombins, right? If you're ever going to push a thrombolytic, now's the time. The guy's only been getting CPR for 2 minutes, not prolonged CPR. If you give the thrombolytic after 20 minutes of CPR, they're going to bleed everywhere. But this guy, we push the thrombolytics, boom, you reverse the Ross.
So if they were doing CPR for more than 20 minutes, you wouldn't push a thrombolytic?
Nope. By that time, the H's and T's, you could have said the alphabet 5 million times. It's not worth it. He's going to bleed everywhere. You got fractured ribs, and underneath the ribs are all the vessels, right? So, I mean, everything's just going to hemorrhage. But if you've had a short amount of CPR, it's probably a good time to do it. Fast forward. Okay, I'm going to talk about the A lines real quick, and then we'll do PA catheter. So with these systems here with A lines, right? Basically, what it is, it's an invasive catheter. It goes in the artery. Okay. Transducer needs to be as close to the patient as possible. The system's kept free of air, and basically you're going to level it and zero it. Whenever we level and zero, we want to be at the phlebostatic axis, which is about at the level of the right atrium. Okay. And when we talk about this, you can see here is the line that goes to the patient, and then this little piece right here, part of the transducer, comes back to an electrical connection, and then it goes to a flush solution. We're not going to flush anything through here. All we're going to do is maintain pressure. If I maintain pressure in there, what it does is as I have pressure going back and forth, it can measure. Okay? And what you'll have is you'll have a pressure bag that you're going to keep inflated at 300 millimeters of mercury, and then your transducer, your three-way stopcock, you just turn it back and forth, and it goes down to the patient's artery. Okay? To set one up, you're going to have a pressure bag, you're going to have pressure tubing, which is rigid, it's not like regular IV tubing, transducer, holder, C-clamp IV pole, and a level. You guys aren't going to be carrying a level, they'll do it before you leave.
They'll be coming with us.
Oh, they will. Not balloon pumps, just A-lines.
Oh, yeah.
Okay? Set up the transducer. Basically, you're just going to pump the bag up, inflate it until it's at 300, make sure that there's no air in the line. Place the transducer right in this upright position. Okay? And again, you see the tubing just goes straight down to this and into the artery. The electrical piece goes back up to the monitor and gives you a reading. And that reading is what we're looking at. Okay, that reading is going to give you an arterial blood pressure, and it's going to give you a waveform. Okay. I'm not going to get into all of this, but you see these here. Each one of these should have a cap on them once they're closed. When it's turned this way, this is off right now to the patient. If I turn it this way, it opens the pathway and closes it to this little opening here. Replace the white caps with blue caps, okay? And you always want this open to the patient. So when I start transducing, I need to turn this little valve towards this thing here, so that I got the fluid in my line connecting with the blood in their artery, so that it moves like this. I get a pressure reading, and then it's diastole. I get a pressure reading, it's diastole. That's what I'm looking for, okay? Systole, diastole. What's that?
I'm saying the plumber didn't design this.
No, right now that's a bad idea, right, the way it is, right? It needs to be open so that the fluid can move through there and I can get a reading. So it's still off right there, okay? And flush until there's no air in the system. Plug it into the transducer just like so, okay? And identify the fourth intercostal space on the patient. Usually it's about even with the nipple line, okay, unless she's 400 pounds and 300 years old. Find the angle of Louis.
You put it down by the knees.
Yeah, put it down by the knees.
That's gross.
Find the sternum, walk it down, you can usually feel it. Okay? And that's usually in line with the right atrium of the heart. Level the transducer at the fourth intercostal mid-chest prior to insertion each time the patient's repositioned. So anytime you sit the patient up above 30 degrees, you need to re-zero the line. Okay? So right now, how do we re-zero? We're turning it off, so the stopcock faces the patient. Okay? We open the air by removing the dead end cap, and you'll get a straight line. There's no reading, right? Because what did we say? We just turned it off to the patient, so there's no more fluid connecting with blood. Okay? And that's when you're going to get your zero. So this is an absolute zero. This is baseline. Okay? What we're going to do is we're going to hit the 0 button, and then that's going to give us our basis. Okay? Then you're going to turn the stopcock back off to the air. You're going to connect the fluid with the blood in the artery, right? So it's stopcock is up so that the pathway is open now. Okay? Replace the dead end cap and make sure the waveform returned to baseline. And there's your waveform. And you can see that dicrotic notch. So if I was using my A line, right there, see this? There's your QRS complex. Right there's the dicrotic notch. What does that mean? It means that the heart just went to rest, and now it's time to inflate the balloon. Okay, so I'm in diastole and I want to inflate the balloon. Does that make sense? That's why we use an A line, okay, as one of our guides for this. We can use the QRS complex or we can use the A line. Either one is fine. Okay, and that's how you get an A line reading. You can see the non-invasive blood pressure is 91 on 64, but the true arterial pressure is 111 on 61. All right. So when you level in 0, this just kind of shows you how to don't worry too much about this. The more tubing length you have, the more apt you are to get an incorrect 0. Right? And yanking it, tripping on it, doing stupid shit, they're rolling it over and it happens a lot. Okay.
Does it make a difference if like you coil it up and, like I say, attach it to like their chest or their arm, something like that?
Yeah,
So it just kind of.
The longer the tubing, the worse off you are.
Yeah.
If you've got a
I'm
lot
saying
of
if you
tubing,
get-
you can ask them, do you guys have a smaller tubing
Sure.
for transport, because we're gonna pull this out.
Yeah.
I always, anytime that, you've heard me say stuff like that to docs too, they get pissed, but I don't really care. It's like, you know that, and I would always, whoever I was flying, Tom Walsh took so many, that kid took a beating, dude. Every time he flew with me, he took a beating. I'd be like, Tom's just gonna yank that freaking thing out as soon as we start. And docs would be like, I'm sure we can get you something shorter. So then they'd have to call the nurse and the charge nurse and somebody go running around, nursing supervisor. But you know what? If the tubing's this long versus something that you got to coil up, it's worth the wait.
Yeah.
I mean, even if you got to wait a couple of minutes, wait a couple of minutes. You don't want to take a chance. But yeah, it was always Tom was always going to break something or pull something out.
Nothing's changed.
No. Kevin Robert too. I used to throw him under the bus quite a bit. They could take it. They had broad shoulders. All right. Let's see. Arterial pressure. Dicrotic notch, we already talked about. Waveforms, okay. So let's, we already talked about this too, central venous pressures. You guys aren't gonna be measuring CVPs, so I'm not even gonna touch on that then. Swan-Ganz, all right, so you might end up using the Swan-Ganz catheter, so I am gonna cover that, okay? For CVP, central venous pressure monitoring, okay, really the big things that you wanna keep on top of is that if you start at point A and you're giving the patient fluid, and you see that their CVP dropped, that's a problem, okay, because they're not improving and they're getting fluid. The CVP should go up as patients get more fluid, not down, right? That's really the main thing that I can tell you about that. And if the CVP is super high and they got Lasix, right, what should it do? It should come down, and if it's not, they're not responding to the treatment. So your CVP tells you a lot about fluid overload and underhydration. So really that's what you're looking at when you look at CVPs. Know your normals. Anything under 3 is concerning, anything over 12 is concerning. All right, so Swan-Ganz.
Where are we going to see most of those patients that they're monitoring? Is it CVA or stroke, bleed patients? Where are we going to see most of the patients that are going to have?
For patients that are cardiomyopathy patients, for patients that are
Sick
heart lung
cardiac
transplants, things like that, patients who probably need to have an LVAD, those are the patients that you'll probably see with these
And they're
types of
concerned with
things.
watching it to make sure that there's end perfusion
Mhm.
is enough. Or
But you know what, okay, so I mean, yeah, that's important, having CVP and knowing perfusion and all that, but your end tidal CO2 tells you everything you need to know about perfusion.
Right.
Because if I'm circulating 5 liters of oxygenated blood and I'm utilizing it effectively, right? I'm giving oxygen 1, 2, 3, 4, 5. You're giving me back H2CO3, H2O, CO2.
It's adequately exchanging oxygen and carbon dioxide.
Right. If I go into shock, right, and I'm only moving 1, 2, 3, 4 liters of oxygenated blood, you're giving me back less H2CO3 because he's making lactic acid then. So that number went from 35 down to 28. So now I'm in profound shock, right? That tells you everything you need to know about end organ perfusion. SpO2 is trapped, you don't need it.
Which is honestly now why a lot of like St. Mary's, when we take SCT runs out of St. Mary's, they won't use a Swan
You don't need
Ganz
it.
or
You don't need it. It's
or
more dangerous for them
arterial
to
line,
place
right.
one if they don't do it with frequency than it is to throw somebody on end tidal and look at end organ perfusion. Are they awake? Are they alert?
Where is it?
Clearview. Structure for possible injuries.
Where?
Clearview.
What's that?
The Clearview Motel?
Oh.
The road.
Really?
Heroin
Oh.
Central?
Yeah.
Is that what that is?
Oh yeah.
Yeah,
Hey, if it's something, call.
and Suicide Central too.
Just bring my camera.
It's drug central, like he said.
They need to
Suicide
go very
Central.
slow.
Prostitutes.
Let it burn. Let it burn.
Scumbags.
Burn the bitch down.
Okay, so this is a PA pacer wire, right?
Too bad. It's too
And the
bad.
PA catheter you can see is longer than the central lines, right? So it's the same thing. It always goes 1, 2, 3, 4 markings, and then you have 2 sets of those, right? So 1, 2, 3, 4, 1, 2, 3, 4. You always have your syringe here.
Okay.
And you always have a balloon that can inflate, right? On this one here, you can see that you've got the right artery infusion. You have the PA distal, okay, so that's the distal tip. This one here this is the proximal, and then this one here is your secondary port, kind of like we were talking about. This one had, or that one has 2 primary ports and 1 secondary port. All right, so how does it work? Okay, here it is, pulmonary catheter. That's this piece here, comes down through the internal jugular. So in this case here, they didn't go through the subclavian, right?
Mm-hmm.
If they did go through the subclavian, it would have come in through that line right there, okay? But you can see it come down through here, proximal port, right? And you see it's in the right atrium, and then you see them drop it down into the right ventricle, and then you see them move it into the pulmonary artery. And what do you notice there? Balloons up.
Okay.
So now, how do I have blood flowing through there? You don't.
Yeah.
Right there.
Okay.
Tick tock, tick tock, tick tock. Basically, right? So if this were one of my carotids, what would be happening? Everything past the point of that carotid would be what? It would be dying on this side. I have collateral circulation though, right? So this side's still getting blood to where it needs to go. You only have one pulmonary artery. So once you inflate this, you're not getting anything through there. Okay? So once that's inflated, you've taken away that. It's think of the pulmonary artery as an airway. Right? Your airway is not redundant.
Yeah.
So if you occlude the airway, that's it. Everything past the airway dies. It's kind of like the pulmonary artery. Does that make sense?
Yeah.
So
Okay.
one path, that's it.
Yeah.
There's only one way on the island, one way.
One way on.
Yep. Here's your intra-aortic balloon pump. And you can see it coming up through the aorta and stopping like right before the subclavian.
So would most common, would they always have this setup? Or-
Usually.
Usually?
Usually.
Okay.
If you got a balloon in there, if you got an intra-aortic balloon in there,
Yeah.
you probably also have a Swan-Ganz catheter in there as well.
Okay.
Okay. Now,
Now, would they ever be circulating oxygenated blood through the stomach, through it, or no?
what do you mean?
Like,
The only way you're going to get oxygenated blood, right, is
Yeah.
for the lungs to give it back to the left atrium and the left ventricle and out. You can't run any blood you run through here is not going to be oxygenated. You're just giving regular blood through it.
okay.
So yeah, it's the only way you get oxygenated blood is by it coming back from your lungs to the left atrium.
Okay.
That's what they're
Way you
doing
get it.
research in nanoscience for.
What's that?
Nanoscience, they're researching those things to put in your blood system.
Yeah.
They'll give oxygen.
Yep.
Okay.
The scrubbers or something like that
Yeah,
they call
fucking
them.
weird.
Some weird.
Beyond my level of expertise,
Yeah.
but
So again, just so that you guys see this, right? Right here is the catheter,
Mm-hmm.
and the balloon is up, and it's occluding. I want that balloon down. See here, I can't get any blood flow past it, and here, I can. So you can be in the pulmonary artery, but you don't want this inflated.
Yeah.
Because again, there's only one path. You see that's the one path, that's it. Once it's blocked, you can't, there's no collateral circulation. Okay? And this whole thing is gonna die. Now, the way I got here might have been
Inflating the balloon.
this right here. So I got into the atria, I got down past that into the ventricle, and I was having a hard time turning this corner. So what do?
Inflate the balloon.
And there it goes. It takes off, right? So it gets some pressure behind it and moves it.
Got it.
Makes sense as to why we use the balloon then, right?
Mhm.
Just to float it.
Floated it.
Okay. Now pressures. Okay, here it is with the balloon inflated. See the balloon's up. Okay, and it's in the right atrium, and you can see that we said that there's very low pressures in the atrium. Okay, the atrium has 30% K. That's it. It's small, right? And if you look at this waveform versus this waveform, that's even a little bit less than 30% of that waveform. Okay, but that's what you're looking at. Is the tallest part of that should be about 30% of this. So right here is floating through the RA, right atrium. As it drops into the right ventricle, you can see higher pressure changes, right? And over here is your pressure numbers, okay? So you can see that when it's contracting, it's way up here at about 30, and when it's resting, it's way down here. And then as it floats further into the pulmonary artery, okay, you can see this here. Again, it's smaller gradient, and then you can see when they wedge it all the way up in here to the point where no blood can get by it, it's wedged, and it's got a crappy waveform. Okay, so if I mark this at 2, when I get there and it's at 2, and I have this waveform, and as I'm doing my transport, I see this bigger waveform take off, I probably moved down to 3. It moved forward, right? Okay, and that's fine. It's right here. But now it's in the right in the right ventricle. Okay, so as it sits in the right ventricle, right here, it does this. and it hits this.
Gotcha. It's stimulating.
It stimulates it, irritates it, right? And what
Yeah.
could happen? You get ectopy. So if you start to see ectopy, what would you do? Pull it back a little bit. That's how you troubleshoot. Pull it back a little bit. It's on the inside lining of the wall of the right ventricle. Just pull it back a tiny bit until the ectopy stops. And then secure it again. Does that make sense? That's your troubleshooting piece there. Okay? So it starts up here. What's my waveform look like? Big or small?
Small.
I'm in the right atrium. Yep, small. Okay? Balloon gets inflated accidentally, right? And I drop down through here, and all of a sudden you see this big, wide waveform. You know you're in the right ventricle, right?
Yep.
And then it comes up here, and now
Goes away.
it goes smaller, right?
Yeah.
You still have a decent waveform, right? Smaller than the ventricle, but then it goes here. And this waveform looks very similar to this waveform, yet you just moved the catheter from the 1 marking to the 3 marking or the 4. You know that's a lot of catheter to move.
Yeah.
Deflate that balloon and you'll see that waveform increase again. That's what we want. Anytime you see a dampened waveform, you've got problems. Okay? The distal port, that's the yellow port, and it lies in the pulmonary artery. Always has to be watched. You can use it to sample mixed venous samples. Okay? Balloon inflation port. The syringe can be locked off, passively deflated, inflate only to the point of wedge. You guys will never ever wedge the catheter. When you do a transport, so here's what you're gonna do. You show up and they have a PA catheter in place, okay? And you know that it's where it's supposed to be. You tell the nurse, can you wedge the catheter for me, please? Why are you telling her that? Because you want to see what the waveform looks like when it's in wedge. And you're going to take a copy of the wedge. Then it's going to come out of wedge and put to wherever it needs to be. When you are transporting, you don't want the change, you don't want the rhythm to change, you don't want the pressures to change at all. You want them to stay exactly the same. If you notice the waveform looks like the wedge waveform, you have to check to make sure that balloon is down and you have to pull it back. Okay? And that's the only reason why you have them shoot a wedge before you go. And they do wedge these catheters about every 12 hours or every 24 just to check them. This thermistor connector, that connects to monitor the core blood temperature and cardiac output. This one doesn't have it because it's just a pacer. All right. Okay. So this right here is just kind of a definition of pulmonary artery wedge pressure. So the balloon blocks out what is behind, it looks forward to the left side of the heart, and the only way that you can get a true reading of the left side of the heart is to block everything from the right, so that's why we do it. So the same kind of theoretical idea behind an A-line where the fluid has to touch each other to move pressures back and forth is the same thing with this. You have to actually occlude the right side so that you get a true pressure from the left. What does that mean? That means that whatever my systemic vascular resistance is, right, on this side, you're moving it all back up through the left ventricle, left atrium, and pushing back into all that system pulmonary circuit, all that. So that's how you're getting a true look at what the true pressures are. Okay, so that's why they do it. You have to have clean lungs in order to be accurate, and it's going to tell you if there's any left ventricle dysfunction. That's what we're looking for, is left ventricular dysfunction with a PA catheter. So we're looking for early signs of what? Cardiogenic shock. And that's why we oftentimes, you'll see USs will oftentimes see a PA catheter in with a balloon pump, because they put the PA catheter in first and they're like, whoa, look at that, pressure's way, way down, right? That's the only way that you're going to get a left ventricular pressure is by wedging the catheter. And they're like, whoop, we got to do something here. Okay. Usually they'll start with pressors, right? Okay. Dobutamine or something like that, levo, and then they'll go ahead and go to the balloon pump. Okay. Trends are more important than actual numbers. What does that mean? I just saw a guy riding a motorcycle there, right? So you got two guys riding motorcycles at 1 o'clock in the morning and they both smash into a pole. Get them to the hospital, they throw a Foley catheter in for transport, right? They've done all the other stuff, these guys are mangled, they both have to go to Albany Med. The guy in the first bed put out 1.5 liters. The guy in the second bed put out 100 cc's. Which one's sicker? I don't know, right? I don't. But I transported them both to Albany Med. The guy that put out 1.5 liters only put out 50 cc's on the way there. The guy who put out 100 cc's put out 400 on the way there. They both got 3 liters on. Which one's sicker? The guy who dumped the initial fluid amount is the guy who's sicker, right? Because he's not responding to fluid resuscitation. So what happened? Well, the guy who only put out 100 took a leak before he got on his bike and smashed it, right? Whereas the other guy should have taken a leak before he got on his bike. So the trend is much more important than a one-time blow. So that's why we always look at trends, all right?
By clean lungs, do you mean fluid in the lungs?
You're always gonna have a little bit of fluid in the lungs, but yeah,
Okay.
when we talk about clean lungs, you want them as clean as you can get them.
Okay.
Yeah.
I was wondering if you meant like COPD kind of thing.
I know that's probably a bad term, but
Yeah.
all of it, COPD, any of that stuff can impact
Okay.
it. So just keep that in mind. Okay, and factors that can affect the wedge pressure: preload or left ventricular end diastolic volumes, ventricular contractility, and afterload. Those are the things that we look for. All right. This right here, pulmonary capillary wedge pressure is high when afterload. Systemic vascular resistance is high, right? So usually what we're looking for is we're confirming low pressure with this thing, saying that the left pump is not working. All right. Reading should always be done at end expiration. What that means is this, right? Normal inspiration interthoracic pressure falls along the central, but why is that? Your interthoracic pump. So if I put air in there, it decreases your blood pressure a little bit. So when you're breathing out, that's when your blood pressure is at its highest. So that's when we do the measurement. All right. All right. So here's your inspiration. There's your expiration. There's end expiration. That's really where you want to measure. And I think that is. Yeah, that's pretty much it. Patient position, remember, you're okay with elevations of 45 to 60, but you have to remember to re-zero any line. Anytime you move above 30 degrees, re-zero the line. Anytime you're above 45 degrees, the line will dampen or it'll fail. Okay? And when we see a dampened line, we're always first thinking it's in wedge. It's in wedge, and you don't want that. So check the balloon first and then re-zero it. Catheter whip, we were talking about that. When it's down into the right ventricle and it's doing this, it's going to create ectopy. Okay? And then these are the complications that can happen. Okay? So troubleshooting, check for air bubbles, loss of connections, excessive tubing again, catheter wedged, and a clot at the tip. Those are, and I think we already hit on pretty much all of those. Migration into the right ventricle, that's when you see that you get this big, wide, 15 to 30 movement. You need to inflate and float it back up into the pulmonary artery and then pull back to the right atrium, either or. Okay? You can either move it forward or you can move it back, but you don't want it to sit right in the ventricle, especially if you're getting PVCs. Other troubleshooting, you're unable to wedge it. You guys aren't going to worry too much about unable to wedge. Over wedge, if you see that the waveform dampens, you need to move that catheter. Okay? And make sure that the balloon is down. Spontaneous wedge, cough, reposition the patient. You can do those things, but just make sure the balloon is down. That should be enough to fix it. All right. And I think that is thermal dilution. You guys aren't going to have to do. That's it. We already talked about, we already integrated all this stuff into. Oop. There you go. Did you guys see that last slide? Let me pull that last slide up.
Yeah.
That one's good. There you go. So this stuff can be overwhelming if you don't do it all the time. Really what you need to look at is you need to take a deep breath, step back, look at the situation, think about normal physiology, think about pathophys, and think about the tool that you're using. Okay? And if you get into trouble, you've always got your med control that you can fall back on.
We'll just call Helen.
What's that?
We'll just call Helen.
I'm going to tell you, the one thing that you don't want to do, and this is not to be disrespectful, but you do not want to ask the emergency room nurse anything about balloon pumps, anything about PA catheters, or anything about any of those items. And the reason being is that that is not their specialty. And if a patient has any of those invasive lines, the better nurse to ask is going to be the interventional cardiology nurse. And the interventional cardiologist probably doesn't even know much about anything other than the balloon pump, because they place those lines, but they don't do the readings and stuff. The nurses do. Okay, so ICU nurse would be your second person to speak with if you had any questions. The ER nurse is just they're gonna give you a line of BS to get you out of the emergency. That's the honest to goodness truth. He's laughing. You know it's true. What are they gonna say? Oh, everything's fine. Just go. Get out of here.
Get them out of here.
Get them out of here, right? That's what's going to happen. And it's not to be disrespectful. It's just it's outside of their scope, because when you work in an emergency room, what's your job? It's to triage and dispo as quickly as possible, right? When you're in the ICU, you're dealing with these people long term, so you have to have a more comprehensive approach. So the point being, if they're doing interventional cardiology, they're seeing it every day. Those are the first ones to go to. And the second point being, if they're not available, then the ICU nurse understands it a lot better than the ER nurse. I think that's pretty much it, unless you guys have any questions. And if you want to go over any of this stuff and ask questions before I leave, I'd be happy to hang out a little while. I'm going to leave all that stuff here, with the exception of the chest. I only have that one quarterback. So, nothing? That's it? No questions?
No, you covered it all.
Answered it?